This is session 144, updates on the management of anaplastic thyroid cancer with Dr. Maria E. Cabanillas. Is an oncologic endocrinologist and associate professor at the University of Texas MD Anderson Cancer Center in Houston, Texas. She is the faculty director of clinical research in the Department of Endocrine Neoplasia at the MD Anderson. As a clinician and clinical researcher, Dr. Cabanillas treats both early and advanced thyroid cancers, including medullary, differentiated, and anaplastic. Her research focus is in the advanced and aggressive thyroid cancer, and molecular target therapies, and in immunotherapy. She is a principal investigator on several clinical trials for treating advanced disease and has been a member of and currently serves on the board of directors of the International Thyroid Oncology Group. She is a ThyCa medical advisor. She is also my doctor. She's also Joel's doctor as well. So welcome, Dr. Cabanillas.
Thank you. All right, well, let's get started because, you know, this talk, I used to have a hard time filling the hour with it, and now it's very easy to fill an hour and more with it. So that's great because it means we've made some real advances in this cancer. And I used the same kind of the same PowerPoint intro slide that I did last year, which says the MD Anderson approach. But you know what's changed is that the MD Anderson approach has been largely adopted and is reflected in the new guidelines that came out for anaplastic thyroid cancer from the American Thyroid Association. So that those came out this year. So we do, a few things a little bit differently, but you'll see that a lot of these things that we were doing before have now been adopted in those guidelines. So you can use that as a reference too. Okay, so let me go to the next slide. There we go. All right, so in terms of background, anaplastic thyroid cancer, it is the most aggressive of the thyroid cancers. It has the worst prognosis. Historically, it was rare to survive anaplastic thyroid cancer. That has changed a little bit in recent years. It's still a rare disease, thankfully. And, you know, the biggest problem with this cancer is that most of the time these tumors can't be removed from the neck when the patient is diagnosed, which poses a huge problem because of the location of the thyroid. It, you know, compresses your trachea and esophagus if it grows quickly. Half of patients already have metastases, meaning that the cancer has moved outside of the neck into other organs. And these are mostly older patients, although we do see patients in their 40s. And, you know, rarely you'll see a 30-some-odd-year-old patient, but that's very rare. The staging for anaplastic thyroid cancer is always stage 4. We have 3 categories of stage 4, 4A, 4B, and 4C. And that's because of how aggressive this disease is and how poor the survival used to be with this cancer. Stage 4A is basically a tumor that can be taken out. These are usually found kind of incidentally. And so you find out that you have anaplastic thyroid cancer after the surgery is done. And 4A doesn't involve any lymph nodes. There's no cancer anywhere else in the body. So these are removed, and then patients get radiation. Stage 4B is a tumor that has left the thyroid gland, so it's moved into adjacent organs, and sometimes have lymph nodes that are involved in the neck. And then stage 4C is that you not only have it in the neck, but also in the lungs. In another organ like the lungs. So I think probably the most important slide here is this one, because it really some people kind of have that aha moment when they go, oh, okay, now I understand how this happens. So anaplastic is kind of the end result of what we call dedifferentiation. Okay, what does that mean? Well, it starts out, you know, that you have these normal cells in your thyroid gland, right? They're we call them epithelial follicular cells. They're thyroid cells. They're normal thyroid cells. They make thyroglobulin, which is a protein that we use as a tumor marker in thyroid cancer. And as these cells, and these cells, make thyroid hormone, they're normal cells. When they acquire a mutation or some type of change that causes them to become cancerous, where they continue to replicate, and you get tumors, um, they can become, depending on the mutation that the tumor has, oftentimes a papillary thyroid cancer. It could be a follicular thyroid cancer or a Hürthle cell thyroid cancer. These tumors usually still make thyroglobulin like the normal cells do, and so we watch that tumor marker throughout the treatment. And these are called differentiated thyroid cancer, or DTC. They have sometimes some very classic mutations. So, for example, in papillary thyroid cancer, we see BRAF V600E mutations. We also see RET fusions, whereas we don't really see those in these other two, follicular and Hürthle cell thyroid cancers. We see a different mutational pattern. When these tumors start to lose a lot of the normal functions of a thyroid cell, such as making thyroglobulin, they start to look less like this normal cell and taking on kind of a different look under the microscope. Um, those are also more aggressive tumors, and oftentimes they're poorly differentiated thyroid cancers. As they acquire more mutations throughout this process, they can become anaplastic thyroid cancers. So as you go down this scale here, you get more mutations, but you retain the mutation that started your cancer. So if it started as a papillary thyroid cancer, you'll still have a BRAF V600E mutation, but then you'll have all these other mutations in addition that probably were not there when it was a papillary thyroid cancer. So that's kind of the easiest way for me to explain how all of this happens, is people want to know how they got this cancer, and probably it's because the cancer was there for a long time and you didn't know it. Medullary is a totally different type of cells from the thyroid gland, and they're on the right here, but we're talking about this side of the slide. Okay, so major changes in the updated guidelines. So the last time the guidelines were written for anaplastic thyroid cancer was in 2012. They were published in 2012. So a very long time passed before we got these guidelines published. And it took us a long time to write these guidelines, because things were changing very rapidly when we started. And and it was a lot harder to write these guidelines, whereas before it was kind of like, most patients need to just go to hospice. You can maybe give them radiation, chemotherapy, but most patients did very poorly. Things changed so much in that past decade that it took us a very long time to publish these. But what I want you to understand is that compared to 2012, what the guidelines basically say is that it's no longer appropriate to just basically tell patients to go home and go into hospice. There are situations where that is appropriate if the patient is very, very ill. But we now actually need to proceed with an evaluation of these patients to see if there's an appropriate treatment. The other major change was that we added that all patients, every single one of them from the beginning, should have their mutation profile done. This is critical because it makes a difference in what treatment you're going to get. Whereas before, in the old guidelines, it said that they didn't recommend it because it didn't really make any difference. Now it does. And so if you don't have your mutation profile, if you don't know it, your doctor needs to send that. It's now critical. Um, there are emerging therapeutics that I'm going to talk about, basically in three categories. Kind of these new approaches are the neoadjuvant approach that MD Anderson basically started, checkpoint inhibitor therapy, meaning immunotherapy, and then combining some of these different modalities. Um, I'm going to skip over this for just the sake of time. But basically, I want to go back to 2014. In 2014, we were approached by a pharmaceutical company to do a clinical trial. We call a basket trial in anaplastic thyroid cancer for patients who had a BRAF V600E mutation. And we agreed to do this study, and it was very challenging in the beginning. The reason it was so challenging is that we didn't ever know what the mutation status was up front for these patients. You know, we tried to get it, but it took so long to get the result, sometimes taking 3 and 4 weeks, that by then the patient was too sick to basically be enrolled in this study. So we had to kind of go back to the drawing board because we really wanted to do this trial. There was nothing really out there for ATC patients that looked promising. And so we knew we had to do it. And identifying the patients that had this one particular mutation, we knew was going to be a challenge. And unfortunately, for some patients, that, it took so long that they weren't able to participate in the study. So we had to, even though it was a lot slower to do this targeted approach method where we said, okay, this mutation is what's driving this anaplastic thyroid cancer, so we're going to put you on this treatment. That took a long time to get that information and to get them on therapy. Whereas before we had like this very kind of cookbook, everybody was either if they couldn't do surgery, then they had radiation. If they did do surgery, they also had radiation afterwards, and they all got chemotherapy. And that was kind of like this, this standard cookbook that everybody did the same thing, right? And so this was a huge paradigm shift for us. And we had to figure out how we were going to do this effectively if we were going to enroll this trial. So right now, the mutations that we consider very important in thyroid cancer and anaplastic thyroid cancer are BRAF V600E, because we now have a treatment for that. Most fusions, which are very rare but do exist, possibly this mutation TSC1 and 2, which is also very rare. So really that leaves us mostly with BRAF V600, but I'm going to talk about the fusions later on. Okay, so how do we rapidly figure out what the mutation is? So what we did was that we adopted what melanoma had done, which was staining the slides. Instead of doing, like, we had to, basically process the tumor and then take out the DNA and then send that for analysis. That took many weeks. What we could do is that we could get a slide of the tumor and stain it for BRAF. This was being done already for melanoma. And we said, well, why don't we do this so that we can figure out who has a BRAF mutation, get them on the trial quickly and move forward. And so that's what we did, but it did come with some challenges. It wasn't that easy to do because we had to validate it and make sure that it actually worked. We didn't want to put patients on a treatment that wasn't going to help them. The other rapid way of determining the mutation profile faster than what the gold standard is, which is to send in, the tumor for the whole profile, so do liquid biopsy, or we just take some blood from the patient and pull out the DNA from that sample that's circulating in the blood, and then do the mutation analysis on that. That was a faster process than doing the full analysis with tumor. Okay, so so we had these two things that we decided we were going to try. We first started with the BRAF, and we eventually were able to validate this test. And the turnaround time at our institution is now essentially 24 hours if you have the tissue. There are some challenges with this test, but if the pathology lab has this immunostain, you can get results very, very quickly. Unfortunately, it only gives you information about BRAF, right? If it's a negative stain, then you're still left with the question, well, what does this patient have then? And then that's when we kind of, decided that we were going to not only do BRAF immunostain on everybody that came through the door, we were also going to do it We were also going to do a liquid biopsy on everybody that came through the door on day one, because because that took a little bit longer to get a result. And so everybody got these 2 tests when they came through the door. The liquid biopsy test, the advantage is that it is faster than the gold standard of 21 days of analyzing the full tumor, but it's still fairly long. 11 days feels like an eternity when you have ATC. Um, there are some issues with recognizing some particular fusions, which are kind of minor issues because they're not very common. But there's no perfect test out there. So we actually, when the patient came through the door, sent all 3 tests, right? So the BRAF immunostain, the liquid biopsy, and then we sent that tumor off to be analyzed for the full mutation profile. That's the gold standard. Okay, so what do the guidelines say? Well, we had a little bit of trouble with coming to a consensus where we would put it in as a recommendation. So this is not a recommendation. Um, Essentially, what it says is that we do the immunostain, but that liquid biopsy is an alternative um, to the more comprehensive, gold standard, but it wasn't actually put in as a recommendation. So it's kind of buried in the guidelines. Um, but recommendation 4 got in there, which was the immunostain for BRAF, strong recommendation. And then, of course, the genotyping, the molecular profile of the tumor, that's the gold standard one that takes 21 days on average, was also a strong recommendation for all patients to have this done when they walk through the door. So that was kind of, that was after many, many years of doing this, we felt pretty great about that recommendation. What about mutation? What about targeted therapy and neoadjuvant therapy? Okay, so this was the basket trial I was telling you about, where we enrolled patients who had a BRAF V600E mutation. This was a global trial, and it enrolled very slowly. It took a very long time. Like I said, it started like in 2014, and the publication came out in 2017. So it did take a while to get enough patients to publish the study. And there were some major problems with the design of the trial that I brought up, but they didn't budge on, which was that patients had to be able to swallow. I would say about 40% of my patients, when they walk through the door, cannot swallow a pill. And so that was a problem, and that's why it took so long to enroll these patients, because we had plenty of patients. It's just that about 50% didn't qualify for the study. But the response rate was phenomenal. It was, a home run, 69% response rate. OS means overall survival. 80% were still alive after 1 year. And that was unheard of at the time. So this was pretty amazing, but you have to remember also, these were kind of your healthiest patients, right? So this is fabulous, paints a really rosy picture. It's really probably not this good. Sorry. Okay. But we did get FDA approval for this combination in BRAF mutated ATC in May of 2018. And then we're updating the data with more patients. The median overall survival turned out to be about 20 months when all was said and done. And patients really felt a lot better when they had a response to the therapy. And we were able to document that with some patient-reported outcome scores. Okay, so this is an example of a patient who we put on dabrafenib trametinib for BRAF mutated ATC. She came to us with a tracheostomy already in place from another hospital. We transferred her in. We quickly determined that she did have a BRAF V600E mutation. She was immediately put on the combination. The point of this slide is just to show you how quickly these responses are. These are very dramatic, and actually I oftentimes will check on the patient a few days later, see how they're feeling. And oftentimes they're already feeling that the tumor's smaller and that they can swallow. So very, very rapid responses, which was very impressive to us. The problem is that eventually these tumors outsmart us. and outsmart our drugs, and then patients stop responding. So this is an example of a patient who put on dabrafenib and trametinib, tumor completely goes away on her scalp there, and then it comes back. And so, we had to figure out how to deal with that. That was a problem um, that is not uncommon, right? So what we were seeing is that about at the 9-month mark to 1 year mark, we were having this problem with patients. And then we were kind of like, well, what do we do now? So we decided to kind of revamp our approach. And I'd had this patient who who I had treated with dabrafenib and trametinib outside of the trial because he didn't qualify because he couldn't swallow. And so I couldn't put him on the trial, but I put him on these drugs and he had a very nice response. And after about 3 months, he came back to he came back to see us and have his scans done. In between, he'd had some issues that I don't want to get into, but we sorted all that out. And he said, well, like, would it make sense to just take this tumor out now? And I kind of went like, oh yeah, of course. Why wouldn't we do that, right? So I went and talked to my surgeon, and he looked at me like I was crazy, but he agreed to do it. And so that's how the neoadjuvant approach started. Essentially, what neoadjuvant means is that you start a patient on some type of treatment, medical treatment, could even be radiation, and then you take them to surgery once the tumor is small enough to take out, because we were seeing that these patients were having these great responses where we were able to take the tumor out now. And so we did. And we published our series of our first 6 patients. This was the index patient where it all started. This is the one that said, well, can you just take my tumor out now? and so he's still alive, and this was a very long time ago. Um, so we published these first 6 patients. This is basically their before and after PET scans. The black in the brain is supposed to be there. So, but this was his tumor, my first patient, and it went down to this little black stuff here. So you see that this is before and after on another patient, before and after another patient. So you see that these great responses, and if we took all these tumors out, what happened to those patients? Well, the their survival was about 83%, which is about what we saw in the clinical trial. Their their survival was longer than that. I don't think we met the median at the time. So, but at 1 year, 80% were still alive. At 18 months, 62% were still alive. This is a small series. Some of these patients, it wasn't homogeneous because some of these patients were put also on a third drug, immunotherapy, which is an approach that we used because we kept seeing these early progression events. And so now our standard of care is that we actually use 3 drugs up front, dabrafenib, trametinib, and pembrolizumab for BRAF mutated ATC. And so we've looked back at a series of 55 patients and published this. Patients who had a BRAF V600E mutation were put on a BRAF MEK inhibitor, and some of them didn't have surgery because maybe they were on the trial or because we just weren't doing it yet. And some did have surgery, and you see that this is a survival curve, and you want to be up here in this line, this orange line. Those patients that went to surgery did much better than the ones who did not go to surgery. So we think that this is a good approach, and we've started a clinical trial. We've started enrollment on that clinical trial to show that. But despite not having a prospective clinical trial, the American Thyroid Association guidelines do reflect that you could do this in 4B patients. This approach of neoadjuvant dabrafenib trametinib as an alternative to just keeping the patient on dabrafenib trametinib without surgery, but only for patients with 4B disease, and we actually do it for all stages of the disease. But this is what we could get into the guidelines. Okay, so that's great. So we made lots of strides in BRAF mutated anaplastic thyroid cancer. We still have things we need to do. Our biggest challenge are patients who don't have a BRAF mutation, And this is not to scare you and make you fall asleep, but it's to show a point, which is that 4C patients without a BRAF mutation, it's kind of like just do whatever you can, put them on whatever you can. So if you don't have a BRAF mutation, you can do this, you can do this, you know, palliative care, best supportive care. It's kind of like, we have a hard time with these patients. But fortunately, we do have some targets in these patients, one of them being RET. RET fusions are seen in papillary, poorly differentiated, and anaplastic thyroid cancer. And so when we catch this, we're able to treat these patients. There are two FDA-approved drugs, pralsetinib and selpercatinib, for this indication. And this is the publication in New England Journal of Medicine where we show the results. The purple patients are the anaplastic patients. You see, we only had two ATC patients. This is one, this is another. One of them had very nice tumor shrinkage, right? So this is a bar showing compared to their scan before being on selpercatinib, how much did their tumor shrink? So you see this patient had a tremendous tumor shrinkage of more than 50%. This patient did not do well though. So, very little data to support use of RET inhibitors in these patients. And I'll tell you my opinion in just a moment. We also have NTRK fusions that we see in papillary and in anaplastic, also very, very rare. And there are drugs for this, both FDA approved. We have some data on anaplastic. 7 patients on the trial had ATC. Those are the ones that are in this green color off to the side here. So you see some very nice responses there. However, the responses didn't last long. Progression-free survival means kind of, how long were they on the trial without their tumor getting worse? And it wasn't very long. It was only 2.2 months on average. And so, and in terms of survival, how long they lived, the median was 8.8 months. So not a home run like we would have expected. These are very short-lived responses. However, in the ATA guidelines, it does say that if there's an NTRK or RET fusion in patients with stage 4 disease, stage 4C, that they recommend a selective inhibitor for those patients, but preferably on a clinical trial. Because if we don't put patients on trials, we're never going to really know if these things work, and it's impossible then to go to the FDA and ask for an approval of a drug for that. So, I have my opinion about those that I'll talk about in a minute. Okay, less targeted meaning, what if you don't have any of those? No BRAF, no fusions. What if you have RAS, or if you have an NF1 mutation? There are a number of other ones. Well, there was this trial from Japan with Lymbatinib that they had a group that had anaplastic thyroid cancer. There were 17 patients, and they had some very good responses, and the survival was fairly good at median of 10 months. However, when we opened this trial here, so we opened a phase 2 trial with Lenvatinib and ATC several years ago, and we actually had to close it early. This is now published. Sorry, I need to update this slide. But a lot of things change in a year. We did have to close this trial early because there weren't enough responses. We're now looking at Lenvatinib plus immunotherapies, combination therapy. Okay, so this is something that we again we put together just to show, does targeted therapy improve outcomes? This is looking at our patients retrospectively, and the patients who had targeted therapy are up here. The ones who didn't are down here. You always want to be on this upper group for an overall survival curve. And so, yes, it looks like there is benefit from targeted therapy. However, in my opinion, I think that single agent targeted therapy is going to be short-lived. I think we've seen that with the RET inhibitors and NTRK inhibitors. I think that the reason that the BRAF patients have a longer time to progression is because they are on 2 drugs. So I don't recommend to my patients single agent drugs. And if we're going to do it, I think we should only do it on clinical trials, but I try not to do this with my patients if I have another option. So what else do we have? Well, immunotherapy is kind of the logical thing to be studying these days. You know, when everybody was wanting to do immunotherapy, we wanted to do immunotherapy too. We jumped on that bandwagon fairly early. What is immunotherapy? Well, you're just basically training your immune system to do its job. Your immune system is supposed to protect you from cancer. It's supposed to eradicate cells that are abnormal and cancerous. And so when your immune system doesn't do that, there's something wrong with it, right? So what we try and do is to retrain the immune system so it does its job properly. I'm not going to go over a lot of this, but the drugs that we mostly use are what we call PDL1 drugs or PD1 drugs, that basically interfere with the receptors between the tumor and the immune system. We try and break that signal. And we do that with drugs such as nivolumab, pembrolizumab, atezolizumab, and spartalizumab, which is not FDA approved, but I'm going to talk about. So by breaking that connection, it's a communication between where the tumor basically is telling the immune system, ignore me. We're trying to break that communication so that the immune system can say, oh, wait, you're not supposed to be here, and attack the tumor. It's another way of approaching cancer. So we do have a published trial on immunotherapy in anaplastic thyroid cancer. This is a drug called spartalizumab, which is very much like pembrolizumab and nivolumab. We had 42 ATC patients that were enrolled in this study, my good friend in Spain, Dr. Cabanillas, is the one. He's the lead author on this. If you want to look this up, this is an interesting trial because it looks at first glance, you say, well, 19% response rate, like, you know, we had 65% in in dabrafenib trametinib. So why am I even showing this, right? Well, if you look closely and break things down by looking at whether the tumor expresses the intended target, which is PDL1. If patients had it, so if you can stain a slide for PDL1 to see, kind of like we do with BRAF, there's an immunostain for that. Patients who had a lot of expression of that marker, PDL1, did much better than patients who had no expression, less than 1 here. So again, you always want to be up here. So patients that had more than 50% expression, patients that had 1 to 49% expression, those patients did much better. They also had a much higher response rate. So the response rate in patients that had 50% or greater expression was 35%. So not as good as dabrafenib trametinib. So I wouldn't recommend this for patients who have BRAF mutation as a single agent, right? I would combine this with other drugs. But this was kind of our first proof that, you know, immunotherapy does seem to be effective in a select group of patients. So the American Thyroid Association guidelines now state that if patients have a high PDL1 expression, and we didn't define what that meant, then they could be considered for first line if they don't have other targetable mutations, right? No BRAF, no RET, all that stuff. Okay, so I'm going to skip over this, but we essentially now add immunotherapy to targeted therapy. That's our standard of care at MD Anderson, because I don't treat anybody with single agent drugs unless I just can't get the immunotherapy. There's now a trial that was just presented at the ATA this month, where this is a German group who they're pretty much almost finished with their trial with a combination of lenvatinib. Remember, that was the drug that I talked about, that the Japanese did that trial. It looked good. We did it. Very few responses. There was 1 response. And they basically added the immunotherapy with pembrolizumab. All patients got this treatment, and just to make a long story short, basically response rate is 68%, right? So this is now kind of what we're seeing with dabrafenib trametinib. How long does that response last? About as long as dabrafenib trametinib, you know, single agent does, about 10 months on average if you take all the patients, not just the really good performance status patients. So not as good, it doesn't last as long. Median overall survival patients, on average lived about 11 months. So again, better than what we found with single agent Lymbatinib, but I think we can do better than this. This combination has a lot of problems. There are lots of adverse events. That's what AE means. And some of them can be very serious and life-threatening, and we have patients die from this. So it's not a combination that I love to give, but many times, we don't really have another great alternative, so we do it. And we're opening a trial with Lenvatinib, Pembrolizumab. We should be opening, in the coming weeks. So that will be only in Houston at MD Anderson, but we will have that option for our patients. So in summary, let's see how much time. Oh, I've gone over a bit. I wanted to give plenty of time for questions. So in summary, basically all patients that have a new diagnosis of ATC need to have their mutation profile done. And if before any treatment is started, in my opinion, every patient should know their BRAF status. If you don't know your BRAF status before treatment, I think you should reconsider starting treatment if that's possible, if it can be delayed a little bit, because we have much better therapies than upfront radiation. Molecular therapy and immunotherapy in PD-L1 expressing tumors seem to be efficacious. We already talked about that, but resistance is really a huge problem, which is why we use this neoadjuvant approach, like try and remove that tumor before it becomes a real problem. And that's a very simplified way of putting it, because there are a lot of other things that we do to keep that response, to maintain that response. It's not so simple, but I don't want to go into all these details because I don't think that's valuable in this type of session. But if you want to ask questions about that, I'm happy to answer them. And then combination therapies rather than using single agent anything, I think is my preference. But that's our approach at MD Anderson. It's not been adopted widely. And then we want patients to always consider a clinical trial, because, if those original, I think we're now up to like 30 some odd patients who participated in that clinical trial for dabrafenib and trametinib, if they had not participated in that trial, we wouldn't be having this conversation today, because the FDA wouldn't have approved that combination without some evidence that it works. And so, we all need to do our part as physicians by, encouraging patients to participate in a trial that makes sense for them, and as patients to also, inquire about any clinical trials that they might be able to participate in. There are a lot of clinical trials. Before, when I first started giving this talk, I can't remember what year it was. It was maybe like 2012. I didn't have anything to show for what trials are open for anaplastic thyroid cancer, because there was essentially nothing. And so this slide makes me smile. It's not because I want you to read it all. I just want you to see that we really do have options for patients. And with that, I will start with the Q&A part of the session. I just want to show you our team at Anderson. We have this very large multidisciplinary team, endocrinologists, surgeons, medical oncologists, radiation oncologists, and basic research clinicians and scientists, and we're all we all come together several times a month to discuss all of our patients, to come up with the best solutions for these patients. And so this is an awesome group. Okay, so I'm going to start with the Q&A. Okay, let me expand it because my eyesight's starting to go. Let's see. What is the difference between anaplastic and poorly differentiated? Yeah, so usually poorly differentiated thyroid cancer doesn't grow as rapidly as anaplastic thyroid cancer, but sometimes they can behave like an anaplastic thyroid cancer. And so We use the clinical behavior as well as the pathology diagnosis, if that makes any sense. But basically, anaplastic, it doesn't look anything like a normal thyroid cell, whereas poorly differentiated has still some features, it retains some features of a thyroid cell, where you can identify, oh, this kind of looks like there's, like a papillary thyroid cancer, or some type of thyroid cell. Whereas in anaplastic, they just look completely disorganized. You can't tell what it is. The pathologist actually has to know that it came from the thyroid gland, or else they can't tell where it came from, because it doesn't look like anything in particular, any kind of cell in particular. Um, okay, let's see. Does using TKI in a patient with poorly diff change the makeup of the tumor? After 12 years, is there a case for doing biopsy in the lung to look at genetics of the cancer? Yeah, we do this. Okay, so basically, does treatment, not necessarily just TKIs, but just any treatment, change the genetic makeup of the tumor? And so would it make sense to do another biopsy after many years? If the patient's been on treatment and something is, it looks like it's not working anymore, like they've developed a new area of cancer that wasn't there before while they're on the kinase inhibitor, I would biopsy that, because yes, it can change the genetic profile. And that's exactly what we've shown in anaplastic thyroid cancers, that if you treat them, that selective, what we call selective pressure, where you're just targeting this one, this one type of cell. If there's a cell that can escape that cell can start growing, and the way that they do that is by acquiring new mutations on top of the ones that they already have, and then they're able to get around the drug. Okay, now that checking for molecular abnormalities is a new standard, are you hearing that insurance companies are more able to approve and pay for the molecular genome testing in the tumor? Yes, we do. Since it's now in the guidelines, I think you need to just show them the guidelines and then say, well, this is what's in the guidelines, and that usually is enough. I know Medicare pays for it. The other thing is that even if your insurance doesn't pay for it, there are a lot of, at least in the U.S., there are many of these companies will do it for free, and many patients they have to apply for it, so it's not an issue. At least we don't have issues with that. Um, okay, someone wants to thank me. Thank you. Thank you for thanking me. If I were to develop one of the targeted mutations in my cancer, and my cancer de-differentiates, as my cancer de-differentiates to poorly diff, would I be suitable for targeted therapies? I have an ATM tumor mutation in poorly diff with bone mets, currently on Lenvima. Yeah, usually we don't see that patients develop a new mutation that they didn't have before that's targetable. So probably you're not going to find anything different. And unfortunately, Lenvima for poorly differentiated is kind of the best thing that we have. Um, there was a trial where we used both Lymbatinib and Pembrolizumab, and so that, and there were poorly differentiated thyroid cancer patients, and so that could be an option for some patients. What percentage of ATC patients are unable to tolerate MEK BRAF due to side effects? Yeah, that we do have those patients. They're not that many patients. We do kind of modify doses and give patients medications to palliate different side effects. But the patients who cannot tolerate dabrafenib and trametinib, what I've been doing is switching them to another combination of BRAF MEK inhibitor called encorafenib binimetinib, because it doesn't cause as much fever, and doesn't seem to cause as many just side effects in general. Sometimes it's very hard to get these drugs for insurance to pay for it, and so it takes a long time to get them approved. But that's one of our strategies, that if we can't keep them on dabrafenib and trametinib, we'll try and switch them over to something else that might be more tolerable. So I would say that it's rare to have a patient that just can't tolerate anything in terms of BRAF MEK inhibitor. I'm on a non-BRAF. I'm a non-BRAF patient of MGH in Boston under Lori Worth, off-label nivolumab, 4 years in December. Doesn't say what the diagnosis is. I don't know if it's ATC or poorly diff. Infusions every 4 weeks. Okay, I don't think there was a question there. Would you use immunotherapy on patients whose tumors don't express the PDL1, the PD1? It's yeah, PDL1. So I do it in combination with other treatments. I'm doing it because I don't know what the answer is. If you don't express PDL1, um, and I put you on 2 drugs, right? A PDL1 inhibitor, right? The antibody, and a targeted therapy. I don't know if you'll respond to that combination better, even though you don't have a PDL1 expression. So I do it. I wouldn't do it a single agent if you didn't have PDL1 expression at all. Is nivolumab FDA approved or still off-label in their eyes? It's still off-label. There's no immunotherapy that's been approved for any type of thyroid cancer unless you have something called high tumor mutation burden, which is rare, even in anaplastic thyroid cancer, called TMB sometimes. Um, and so there are special circumstances where you can get it for patients because they have a particular aberration, which we don't often see in anaplastic. So, but in most cases, it's off-label. What is your criteria for high PDL1 expression? I knew someone was going to ask me that question. I don't know. I don't know what the answer is to that. I would say that any expression of PDL1 is sufficient for me to say, let's try this. Um, I don't know if there's a cutoff. We'd have to do the studies to understand that better. We are looking at that in the Lymbatinib Pembrolizumab study to see if that does correlate with responses. Are patients who have ulcerative colitis in remission bad candidates for pembrolizumab trials? Yeah, so if you have an autoimmune disease, especially something like an autoimmune colitis, we don't like to put patients on immunotherapy for that reason. And so we might put them on a different combination. For example, if they didn't have a BRAF mutation, we might put them on lenvatinib, everolimus, which is another combination I didn't talk about because we don't have good data to support it. But that might be another an option for patients who don't have who have kind of a contraindication of going on immunotherapy. Other things like rheumatoid arthritis, things like that, I avoid putting patients on immunotherapy. Um, but there are it's not kind of a hard no, right? Because we do have good drugs to help these patients if they do get colitis. Um, so I think in most cases the answer would be I wouldn't put them on, but could there be a circumstance? Maybe. How feasible is it for UK-based patients to enroll in trials at MD Anderson? The patient could meet travel costs. Yeah, so that's a good question. This is always a really difficult issue that we have because we have patients overseas that want to participate in trials and are willing to come for their appointments. However, it's not just the travel costs that need to be covered by the patient. The cost of a lot of things that we do on the trial when the patient's on the trial is what we call standard of care, meaning that the insurance picks up that bill. So if I have to put you on chemotherapy, regardless, if it's a trial or not a trial, I'm still going to be doing visits with you, labs, scans, all these things that EKGs that need to be done for safety reasons. And the insurance company picks up that bill. There is a rare patient that has been able to participate in clinical trials and actually has paid out of pocket for all those bills, but it can become very, very expensive, especially as these patients, seem to be living longer and longer. When I opened my first combination trial, different combinations in with immunotherapy in ATC, which I didn't talk about for the sake of time. I didn't expect the trial to still be open at this point. I mean, we have patients who are alive on that trial. That's the Atezo trial for years, and so I some patients can be on these studies for a very long time, and it would be very, very expensive. But there are patients who are able to pay that. What do you know about the A1C100 trial? I don't know anything. Reintroducing re-engineered cells back into the body. Okay, that's probably it. There are these different trials where we manipulate the immune cells, either by taking them out um, and um, and and expanding them, like making lots of those and then giving them back to the patient. There are also trials where we engineer the cells to recognize a particular target, like CAR T cells, and give those to patients. So these are studies that haven't been yet been published. There is, I'm not sure if that's the trial that particular trial that you're talking about is the CAR T trial. I suspect that it is, um, which opened last year, I believe, and has enrolled some thyroid cancer patients, but they're not all ATC patients, but they can be enrolled in that study. That study is at Cornell. We are trying to open it, but unfortunately, we've had a lot of problems with our IRB allowing us to open that trial. If dabrafenib alone gives stable disease, PDTC, for 1 year, would you still consider adding another drug before progression? Not for poorly differentiated, we don't do that. We wait. In poorly differentiated, we wait. If the patient starts to look like they're having progression, then we add it. We add other drugs. Um, so we don't. Whereas in anaplastic, we start all of them at the same time up front, or as early as we can. How common is it for poorly diff to become ATC? Well, we don't know what the answer to that is, but that does happen. Um, all cancer, all of these thyroid cancers can transform to ATC. Even poorly like well differentiated thyroid cancers can also de-differentiate into ATC, but we don't know how often that happens. It's not super common. Can adding immunotherapy to dabrafenib mechanism be done in someone who is autoimmune? I think I talked about that already. Is the option to do surgery following medical treatment differ by location of the tumor? Mediastinum question mark. Anyone go from the PLX 8934 trial to another therapy? Okay, so is the option of doing surgery following medical treatment, does it differ by location? If the surgeon can reach it through a neck incision, then we will do it. If it's kind of deep in the mediastinum with different lymph nodes, that's not something that we take out. That's something that we treat with medical therapy. And I don't know if anyone has gone from the PLX trial to another therapy. Papillary, but now with BRAF on mechanism Tafinlar combo, that's dabrafenib trametinib, since December 2019 had initial reduction of tumor load by almost half, but now stable on scans for 9 months. How long should you expect it to remain stable? For papillary thyroid cancer, it can be a lot longer. We did a clinical trial with the combination. I don't remember off the top of my head how many months the median progression-free survival was, but I think it was about 18 months, 15 to 18 months, if I remember correctly. So that's the median. That's just the middle, right? And so there are patients who respond less time, more time, but you can expect somewhere probably about 1.5 years is what I usually tell my patients. But we have patients that go longer. Theoretically, why would multiple drug therapy be preferable to single drug therapy? Well, first of all, I'm talking about ATC only. But the trials that we've done with single agent drugs they're not promising. I mean, if you look at the Lymbatinib single agent trial in the US, very few responses. There's one response. And that was out of, I think, more than 20 patients. The NTRK inhibitor study with larotrectinib, we had 7 patients in that study, so very small, but the median progression-free survival was 2 months. So not great. the RET inhibitor, not enough data, but I suspect if we did have more data, it would probably look similar. But that, that's why that's not in the guidelines, but that's my opinion, is that single agent doesn't work. Why would that happen? Well, because when you're just targeting one thing in a cell, there are cells that are able to, to figure out a way to get around that drug. And in a rapidly expanding tumor, those cells are going to overwhelm the other cells, right? Very quickly grow out of control. So in anaplastic thyroid cancer, when that happens, patients get into trouble very quickly. So that's why I don't use single agent. In your
Just
experience,
a quick, Dr. Cabanillas, just a quick time check here. We're about 2 minutes left. We have one
Okay.
question left. So do you have any closing remarks, or do you want to get to the last question, or do you think you can do both?
I think I can do the last question. In your experience, how long do your BRAF mutated ATC patients continue on dabrafenib for until resistance is built up? So we use, like I said, we use triple therapy, and our data suggests that, well, we don't know because we haven't actually, looked at the triple combination therapy, and it's variable between different patients. But we're seeing patients who are on these therapies now for years. Not everybody, doesn't always work out that way. Unfortunately, there are some patients that just don't respond very well or for very long. But we do have a lot of patients who've been alive for years. So I can't tell you a number because we haven't actually looked at our data. We should look at it. Okay, so with that, I guess we can close. Thank you for being here. And if you have any questions, you can, I guess they can probably send them through me, through ThyCa somehow. I don't know, Christopher, is that okay? They send them to you guys, and then they can ask me. You guys can send me their email or something.
Yeah, we'll figure out a way to get it to you.
Yeah. Okay, great. Very good. Thank you for listening.
Dr. Cabanillas, thank you so much for the presentation. Awfully encouraging with the results of the past decade, and also for powering through almost 20 questions. Amazing. Thank you so much for your time and for your work. Lots of thank yous came in that we didn't get a chance to share, but everybody's quite appreciative of all the hard work you're doing, and keep it up. It's very encouraging.
Thank you. Thank you. Have a great weekend, everybody. Bye-bye.
Bye-bye.